Hello everyone, and welcome to CRAMsurg, Clinical Research, Appraisal and Methodology for Surgical Trainees, where we pick a paper fresh from the press on a hot general surgical topic. We review it for you, we present it for you, we critique its methodology for you, and provide top-of-the-field expert opinion and teaching on research, appraisal and methodology. My name is Gio Perrin, and together with Professor Sababala Subramanian and Maria Digby, we bring you CRAMsurg from the wonderful region of the Yorkshire and the Humber. Welcome back everyone. Today we're going to have a look at a very interesting paper looking at the use of antibiotic bowel preparation before rectal surgery on top of mechanical bowel prep, the Mobile 2 randomized control trial. Following that, we'll have a brief chat about the design and issues associated with factorial design multi-arm trials. I'll leave you to it.
Hi everyone, I'm Chloe. I'm a surgical training lead, work with Gio there. So what we are presenting today is a paper that's been published recently in March in JAMA. Quite a good journal, and it's by Helsinki University Hospital. And what they're looking at is a randomized controlled trial, looking at morbidity after mechanical bowel preparation and oral antibiotics prior to rectal resection.
Right, a bit of background about what this is all about. Well, we do know that surgical site infections are a big problem. They trouble our colorectal patients particularly quite a lot, 10 to 20%. We did talk about this on our most recent journal club as well. And we do know that SSIs and anastomotic leakages do contribute massively to morbidity and mortality in our patients. In the context of particularly left-sided colonic resections and rectal resections, there are a variety of guidelines suggesting that perhaps mechanical bowel preparation helps. That includes the UK guidelines that do recommend it for left-sided colonic resections. Less commonly recommended is antibiotic preoperative bowel preparation. And some guidelines do recommend it, some other don't, as you can see on screen. Generally speaking, there's a feeling that there's a lack of high-quality evidence concerning antibiotic preparation, even if they've been around since the 80s, if not the 70s. And this is where this RCT kind of sits, trying to shed some light on the topic. So ball back to you for the PICO.
So just a quick summary of the paper. In terms of the patient cohort, they have essentially included patients who have been scheduled for all elective anterior rectal resection. That can be colorectal or coloanal anastomosis, and they need to be obviously diagnosed with a rectal tumor. And the time frame are patients who are scheduled for surgery between March 2020 and October 2022. The intervention which they're trying to compare is mechanical bowel preparation alongside oral antibiotics. And within this context, it is 1 gram of neomycin and 1 gram of metronidazole orally taken at 3 and 11 o'clock on the day prior to surgery. This is compared to a normal baseline of mechanical bowel preparation, but a placebo is given to the patients rather than antibiotics. And the primary outcome is a 30-day comprehensive complication index, which I will abbreviate as CCI subsequently.
Excellent. So as you can probably guess, this study is designed as a superiority trial aimed at determining whether mechanical bowel preparation plus antibiotics reduces the overall complication rate after elective rectal resection when a colorectal or a coloanal anastomosis is performed. This is compared with simple mechanical bowel preparation. Ball back to you.
So going briefly into the study design, a few things of note is that first of all, this is a double blind. Essentially, patient is blinded and clinicians are blinded as well. There is a placebo involved, so compared to having antibiotics, and it is obviously a randomized controlled trial. It is a multi-center trial involving 3 large university hospitals in Finland, which serves about 70% of the Finnish population, and it is held across sort of 3.5 years as established earlier.
So the authors implement a few measures to make the trial more reliable and internally valid. They use computer-generated variable block sizes, which helps with allocation concealment. The methods by which they deliver the antibiotic and the placebo is pretty solid, I would say. It's described very well in the paper. And they do stratify patients based on some tumor characteristics and some characteristics of the treatment that the patients have preoperatively. Particularly, they choose a cutoff of 10 centimeters from the anal verge measured on MRI or endoscopy, and above or below. That's 2 stratas. And preoperative treatment, which could be no preoperative treatment, a short course radiotherapy, with immediate surgery versus long course chemoradiotherapy. The radiotherapy and delay goes with the long course chemoradiotherapy in this case. The design is double blind, as I mentioned earlier on, and they do use some multiplicity correction when they do the subgroup analysis, which again is described very well in the methods. Ball, back to you for a bit more.
So looking at the outcomes that the authors have chosen, the study design was designed to end at 6 to 8 weeks after surgery, and this is concluded with either a form of abdominal imaging with PR contrast or a sigmoidoscopy, and they assess the occurrence of complications of deaths at the endpoint. The primary outcome, as established earlier, is CCI at 30 days after surgery. And they looked at a number of secondary outcomes as well, including a 30-day surgical site infection rate, the number and severity of anastomotic dehiscence, and length of hospital stay. They also looked at mortality rate at 90 days and number of patients who required adjuvant therapy.
So going into results, the patients included in the study had fairly sort of equal characteristics amongst the groups considered. That applies both to the baseline characteristics, the tumor characteristics, as well as the treatment they have received. They're pretty much identical if you look at the tables on the paper. Overall, 765 patients were assessed for eligibility. Ultimately, just above 600 were randomized, and 565 were included in the final analysis. 277 in the mechanical and antibiotic, and 280 in the mechanical plus placebo. Paul, back to you.
So looking at the primary outcomes and the secondary outcomes, just for those who are not familiar with the CCI, it's scored across 100, and so it's 1 to 100. So overall, the key finding was that patients who received antibiotics, they did have a significant fewer overall post-operative complication rate, with a significant difference in CCI scores as shown on the screen. Going on to secondary outcomes, patients who also received antibiotics, they did get fewer surgical site infections, and they also had fewer cases of anastomotic dehiscence. They made a note that there are similar rates of superficial and deep incisional infection, but there is a decrease in organ and space surgical site infections, which is, we think, probably related to the rates of anastomotic dehiscence.
So if you look at then length of hospital stay, this is pretty much equivalent, as well as the need for adjuvant therapy. They had 3 deaths in the mechanical and antibiotic group, and 2 deaths in the mechanical antibiotic and placebo. And as you can see, those are things that kind of, I wouldn't say common, but known to happen in patients that have significant chronic resections like the one included in this study. One adverse reaction was recorded, and that had to do with a C. diff infection case in the mechanical and antibiotic group. Paul, back to you.
The authors did perform a subgroup analysis, and the results demonstrate that the reduction in complication rate is primarily in a group of patients who have, number 1, low rectal tumors, they either had a short course of chemoradiotherapy or no chemoradiotherapy, and they tend to have protective stomas, and they tend to have open surgery. Going on to the limitations of the paper, the authors did report a few sort of self-limitations. First of all, there's quite a small group on subgroup analysis. Their patient cohort did have quite a high rate of open surgery, which might affect external validity. And it is noted that it is within this paper, the infection rates are determined by the surgeons reporting their own infection rates within their cohort, which might affect sort of the bias of the results.
Excellent. A few more points that we picked up. The first one has to do with terminology. So the authors describe some of their operation as partial TME versus total TME, and I'm not entirely familiar with what that would mean. Maybe someone in the audience can help. And certainly I couldn't find the definition in the paper itself. About 75% of the surgeries performed here were open, which seems to me rather high in comparison to what we do. The inclusion criteria for this study do include benign tumors, but 1 in 10 of the cases included in this study are benign tumors. I'm not entirely sure if that's because simply other ways of approaching these tumors are not available, such as TAMIs or ESD, or if simply there are different criteria for accessing those techniques, or simply I'm not understanding what they mean by benign tumors, because to me that just means basically a large polyp. If you look at then the characteristics of the patients in the tables with a bit of a sort of critical eye, you realize that about 2 out of 10 of the patients included were T1 and T2 tumors, but 65% of patients had no new adjuvant treatment. Now, if I look at the patient's characteristics, I would think that in our MDTs, in the UK MDTs, a lot more of those patients would have received neoadjuvant treatment. So I'm not entirely sure if that is because of a choice that's dictated by perhaps national guidelines that are different from ours, or given that a lot of patients are ASA 3 and 4, their fitness. And obviously that does have strong implications in terms of the external validity of this study. Finally, well, not exactly finally, the surgeon performing the procedure does have a choice in terms of deciding to defunction or not defunction a patient, which does obviously introduce an additional type of bias, which relates to the risk perception that the surgeon have for the procedure. And there will be risk avoiding and risk seeking patterns or behaviors that can affect the results. So you would assume that they're randomized equally across the 2 groups. That's not necessarily true because they've not stratified for that. And they also don't know how many surgeons are involved in this. The study is designed to detect a 5 points difference between the 2 groups. And if you remember what we said, the CCI scored a 0 to 100. Is 5 really a clinically relevant difference between the 2 groups? I'm not entirely sure. And I'm not entirely sure how the researchers decided that that was the right threshold to choose. Nevertheless, that's what the study is designed for. So, Bob, back to you for conclusions.
So overall, as we've mentioned a couple of times, the authors have concluded that the addition of oral antibiotics to mechanical bowel prep does result in fewer overall postoperative complications. This includes fewer surgical site infections and anastomotic dehiscence compared to patients who simply have mechanical bowel preparation alone. And the keynote is patients undergoing elective rectal resections. The table on the screen just summarizes the points that we've discussed earlier.
Thank you.
Just a brief summary of what we discussed. after the paper presentation. We discussed the relevance of antibiotic prophylaxis and the purpose of antibiotic prophylaxis in the context of a subset of patients already receiving antibiotics for the purposes of bowel preparation. And we highlighted how there is a difference in scope comparing the two types of treatment. We then reiterated some issues with external validity and applicability of the results of this trial to daily practice. And finally, we discussed how, despite guidelines in the UK recommending bowel preparation mechanical for left-sided colonic resections, practice is actually extremely variable, and not just between units, but also between surgeons within the same unit. So certainly we felt that this paper did fit well, highlighting a significant gap in the evidence. And overall, we felt that this was a very well-designed randomized controlled trial. I'll leave you to the teaching presentation.
I won't take you for too long. So we're going to talk about factorial design and factorial trials. So let's start, first of all, with the definition. What is a factorial design RCT? It's a randomized controlled trial where two or more randomized comparisons are carried out independently on the same sample of patients. And we'll go into a bit more details about what that means. How common are factorial RCTs? Not very common. We said last time that multi-arm RCTs represent about 10% of the total RCTs that are registered at the minute. Factorials are about 1 to 2%. So not very rare, but certainly not very common. So what do I mean when I say that multiple comparisons are run at the same time? When you're running a factorial randomized control trial, and the simplest factorial randomized control trial is a 2x2, you are randomizing all patients to two treatment A and treatment B. That means that a patient can have treatment A and treatment B. A patient can have no treatment A but treatment B. A patient can have treatment A but no treatment B, or none of the above. And effectively, there are 4 treatment arms. And we will go into a bit more details about what that actually means and how it is actually done in a minute. But similarly to what we said last time, at the end of the day, would it be multi-arm or a multi-arm with a factorial design, it is still an RCT. So again, we need to remember, as we discussed in numerous videos and numerous appointments we had before, that there are some specific things that we need to remember about RCTs. And if we choose to complicate things and mix them up a bit, we still need to have a very good reason to do it. Generally, similar to what we discussed last time, that reason would be that the sample size to run a trial like this is smaller than the one required to run 2 randomized controlled trials. And we'll see the limitations of that. So let's start by talking some more definitions. When we talk about factorial design, we talk first of all about factorial randomization. And factorial randomization is what we just discussed. So basically, a patient can be randomized to any treatment or combination of treatments included in an RCT. That differs from factorial analysis. A factorial analysis, whenever you are analyzing the data afterwards, you are comparing all the patients that ended up in treatment A versus all patients that ended up in non-A. That is different from comparing the patients that ended up in group A versus the patients that ended up in the placebo-only group. I hope that makes sense. Furthermore, when you say factorial design, you mean that both factorial randomization and factorial analysis are carried out. But to complicate things even a bit more, there is a thing called partial factorial design, where you can selectively exclude some patients from a particular randomization. And we will talk about some example later, but there are some patients that can be included in a factorial randomized controlled trial, and they might be eligible for treatment A, but they might not be eligible for treatment B. So they are selectively excluded from being randomized to treatment B because they're not eligible for that. And that does not necessarily affect the validity of the trial or the design itself. It's just called the partial factorial design. So, why are we running factorial randomized controlled trials? First of all, we need to ask ourselves, what is the research question? We had a very similar approach last time, but basically, first of all, we could run a factorial randomized control trial because we're interested in knowing what treatment A is doing versus control, which could be placebo, and what treatment B is doing versus placebo. That's similar to running a multi-arm randomized control trial where you're just using the central arm, the control arm, as a control for both treatments. That's as simple as that. But there is also an option where you are interested in knowing what A is doing versus no treatment, B is doing versus no treatment, and what A is doing versus B. And this is something that you can do in a factorial randomized control trial, but you need to remember a few things before starting your trial itself and designing it. And finally, what happens most of the time is that we are in a situation where we are in between 1 and 2. So yes, we are designing a randomized control trial with factorial design to know what A is doing versus control and B is doing versus control, but also we are a little bit interested in knowing what A is doing versus B, or if A has an effect on B or B has an effect on A, something like that. Sometimes it's very clear when you read the paper and you read the methodology and the way the paper is designed, the trial is designed. Sometimes it's not so clear, but we'll talk about some examples. The important thing to remember is that whenever you choose a particular research question and you have a particular purpose in mind, that does have implications in terms of the assumptions you make and in terms of sample sizes. So let's start with analyzing scenario 1, when we are just interested in knowing if A versus control and B versus control. That's it. So the assumption that we are making is that A and B are really not interfering with each other. And therefore, even if we are using as control a patient that received B, we are not that upset. We think that our primary outcome that we're interested in when we're testing A is not going to get affected. And plain and simply, if you're designing a trial like this, when you are calculating your sample sizes, you simply do a sample size calculation for treatment A, a sample size calculation for treatment B, and then whichever one is the biggest is the one that wins and is the one you're going to design your trial on. And let's talk about an example. So this is a trial that was actually is now relatively dated. It's 4 years old. And it was a pragmatic multicenter factorial randomized control trial looking at the reduction of surgical site infections called the Falcon trial. And as you can see, a few interventions are performed there. One is 2% alcoholic chlorhexidine and versus povidone iodine. And the other one is coated suture versus non-coated suture. And patients can be randomized to a variety of combinations. And as you can see from an extract from the methods session of this paper, the authors do assume that there is no intervention interactions. That means that using 2% alcoholic chlorhexidine versus a coated suture and non-coated suture in presence of a coated suture or non-coated suture will make no difference in terms of the infection rate. And same applies to the 10% povidone iodine. This study then recruits a number of patient sufficient to demonstrate a statistically significant difference for one or the other comparison, depending on which one requires the highest number of patients. Plain and simple. But let's have a look at scenario number 2, where we are interested in both knowing what A performs versus control, B performs versus control, and what A performs versus B, or in combination with B. So in this case, we are assuming that A and B do have something to do with each other, or at least they do influence each other. Becomes a little bit more complicated to then do sample size calculations. First of all, because we have to decide in which direction the interaction between A and B is going to go. Are A and B going to work synergistically towards achieving a better outcome? Or are A and B going to work against each other? Or and when A and B are working synergistically, are they working in a summative way or a multiplicative way? That does make that does create a lot of repercussions in terms of when we calculate our sample sizes and the validity of our results and the reliability of our results. Magnitude of interaction is also important. And generally speaking, if you're interested in knowing what is the effect of an intervention versus another in a factorial randomized control trial, you probably need to increase your sample size. Most certainly you do. It's the magnitude by which you need to do it that is different depending on a number of factors. And this is an example, a very good example that was published in the New England Journal of Medicine a few years ago. So this is a factorial trial of 6 interventions for the prevention of postoperative nausea and vomiting. So as you can imagine, patients can get, in this context, randomized to a number of groups. And this diagram is quite complicated, but as you can see, a number of possible combinations are contemplated by the people that designed this study. And if you then go into the method session of this study, you will realize that the authors did put a lot of thoughts into it, and probably that's why they got it published in the New England Journal of Medicine and not in colorectal diseases, apart from obviously the topic being different and the magnitude of the study being different. But as you can see, the authors looked at the sample sizes required to both look at the single interventions versus control, but also look at bundles of interventions such as 3 factors and 2 factors. And they realized that when they were looking at 3 factors together, they actually needed to recruit a much higher number of patients. And they also took into account the potential effect size of the combinations versus the single treatments that they were providing. And obviously did that quite well. So the vast majority of factorial randomized control trial that you find out in the literature are actually probably sitting in between 1 and 2. And we did review one of these in episode 15, which is now nearly 3 years old. That was the Lapsis trial. And if you go online and have a look at it, you can see our take on that at the time. And this was a factorial randomized control trial, synthetic versus biological mesh and laparoscopic versus open surgery for ventral hernia repair. And the authors here kind of fly over the issue of interaction between the treatments that they are offering patients. And it looks like they calculated the sample sizes based on the assumption that there is no interaction. But if you think about it, and I'm sure most surgeons that do any abdominal wall surgery will agree, there certainly will be a degree of difference in recurrence rate, and using synthetic versus biologic and laparoscopic versus open, depending on the combination you end up with, there will be a degree of interaction, at least. I think there will be, particularly in terms of SSIs. So ultimately, when you're choosing to perform a factorial randomized control trial, you've got to think of the pros and cons. What is the reason for doing it? As we said, we are complicating our life, and we are introducing potential further sources of bias and or things that could potentially affect our ability to make solid conclusions. So there are a few things that are worth considering. One we already talked about, and it's the interaction, but there are also some practical considerations that one should make. Suppose you want to test to make two comparisons, and you are providing your 2 interventions to your patients. Ideally, you want to administer those interventions together for practical purposes. You don't want an intervention to be done at day 1 post-op and one to be done 7 days post-op, because it becomes a little bit messy to make sure that all the patients are located in the right spot and they are receiving the right intervention at the right time. So generally, if interventions are administered at different times, it's probably a bad idea to do it, but still possible. Eligibility. Ideally, if you're designing a trial like this, you would like the vast majority of patients that you include to be eligible for all the treatments you are experimenting on. Otherwise, you will end up having some patients excluded, which is doable. You just have to kind of try and predict how many are going to end up in that situation, and then do a partial factorial design. Recruitment, adherence, and dropout can have massive consequences in a factorial trial. Suppose you are trialing a chemo drug, and a significant number of patients are getting some side effects. Now, if you're just doing that chemo drug versus placebo or versus standard of care, fine, you're going to lose some power in your comparison. But if you are doing this in the context of the factorial RCT, you're going to lose patients on both comparisons. And that can have massive consequences in terms of the results of your trial at the end. Interim analysis can play a different role in this context. Ideally, you should be able to selectively stop one particular intervention when you feel that that intervention has become futile or has an excessive amount of side effects without affecting patients that are in the trial and are receiving the other intervention. And obviously, there's an issue with multiplicity. Ideally, if you're doing a factorial design randomized control trial, you want a situation where multiplicity adjustment is not necessarily required. And if you go back to my presentation from last month, multiplicity adjustment is not mandatory all the time. But if a lot of adjustment is required, no, generally speaking, your results will be more diluted. So nearly at the end, when we're talking about interactions between the treatments that we are experimenting on for this type of randomized control trial, we need to remember that they do affect the sample sizes that we need. So the first question that we need to ask ourselves is, do we care about the interactions between treatment? Are we going to compare those treatments with each other or just against a placebo? And if we do care, then is it then relevant to the study? And ultimately, as I mentioned, we need to go back to the research question to determine all that. And in practical terms, there's not much out there to tell you when you should really be worried about an interaction between treatment and when it stops becoming advantageous to run a factorial design trial rather than two separate trials. But generally speaking, the number that I found out there is that if the overall effect of the interaction hits about 30–40% of the effect size for the single interventions, then designing a factorial randomized control trial with a sufficient number of patients to actually compare the two interventions that you are testing becomes impractical. And at that point, you might as well design two separate RCTs comparing two separate treatments with two lots of placebos or two lots of standard treatments rather than doing a factorial design, because otherwise the patients that are receiving both treatments will be significantly affected by the interaction, and you won't be able to pick up, you won't be able to compare the two treatments. To conclude, factorial trials are types of multi-arm trials. Factorial randomization and analysis can be conducted separately. Interaction is the key issue to remember when you're designing a factorial randomized control trial. And remember, the practical issues can affect the other arms significantly. And practicalities are very important when you are looking at factorial RCTs. So at the end of the day, it's again all about the question. And similarly to what I mentioned last time, these trials are becoming more common, so extension of reporting guidelines are available specifically for this particular type of randomized control trials. And I will stop here.
Thank you everyone for tuning in and listening. Until next time, keep running your life with our surgical podcast.